Good morning, everyone. A warm welcome to everyone to the South Zone SZISACON 2023. Let's begin the scientific committee for the Hall B. Anesthesia began with introduction of ether to alleviate the pain of surgery, but today it has progressed to an extent that pain and palliation has become a subspecialty by itself. Our first session for today is about cancer and chronic pain. I welcome the chairpersons for today's session, Dr. Akka Mahadevi, Professor and HOD, Department of Anesthesiology, Wayanad Institute of Medical Sciences, and Dr. Pratibha Mache, Associate Professor, Head of Pain and Palliative Care Unit, a winner of a Best Low-Cost Pain Treatment Award, one who has been preaching and practicing pain extensively in Mysore. I request Dr. Akka Mahadevi to introduce the first speaker of today, Dr. Namratha ma'am.
Very good morning, everyone, and it's really my proud privilege to begin talking for the day. So it's a real honor to introduce Dr. Namratha Rangnath, our very close friend. Her designation is she is professor and former head, Kidwai Memorial Institute of Oncology, Bangalore. 27 years of experience in onco-anesthesia, and her areas of interest, head and neck oncosurgeries, thoracic anesthesia, and prehabilitation. So I don't hesitate to say that she is an excellent academician. Over to you.
Good morning, everyone, and thank you so much for such kind words, and having two beautiful ladies as my chairpersons, it gives me a pleasure. And actually, I was happy to see the chairpersons and the speakers who were next to me, because I thought at least those 5 people will be there to listen to my talk. So I'm thrilled and to have some more people around. So the topic given to me by the organizing team is anesthetic implications of post-chemotherapy and radiotherapy. As all of you know that cancer remains a leading cause of death worldwide. An estimated 9.6 million deaths were attributable to cancer in 2018 according to the data from WHO. Historically, surgical resection of tumor was the mainstay of treatment for many cancers. Anti-cancer therapies, including chemotherapy, radiotherapy, and immunotherapy, have been introduced as adjuncts, allowing for less radical surgical approach with improved outcomes. Now, we wonder why this topic is given, because this topic, not many people are interested, but it's such an important topic, especially for the postgraduates who finish their MD. They go for private practice, they go and do a CA breast thinking it's a very small surgery, a superficial surgery. They don't get investigations done, they don't ask what chemotherapy was given, and they don't know the effects of the chemotherapy which the patient had, and how they could have improved, and they can have a calamity. So that is one thing very important for them to know about radiotherapy, chemotherapy as well as radiotherapy. Because radiotherapy, especially for a difficult airway, because if radiotherapy is given in an area where head and neck area, the chances of we having complications with airway management are much, much higher. So a question asking about where RT was given, where radiotherapy was given is very important. So in last few minutes, I'll take you in a nutshell with chemotherapy and radiotherapy, what we should know about it, and how we should, examine the patient before we take them for surgery. So chemotherapy, it has a very versatile role in cancer treatment. There are 3 types, like neoadjuvant is given prior to surgery in order to reduce the tumor size. Adjuvant is given during or after surgery in order to reduce the risk of cancer recurrence. Please, can you close that door? I can hear the other speaker. Palliative, where there is no curative intent, but it is used to prolong survival or improve the quality of life. Thank you. Neoadjuvant therapy comprises either of chemotherapy, radiotherapy, and immunotherapy alone or in combination before surgical resection of tumor. So what does chemotherapy do? It treats both the primary tumor and the possible distant metastasis, but it not only targets the rapidly dividing cancerous cells, but also non-malignant cells, and thereby inducing toxicity. And toxicity leads to serious adverse effects that can worsen a patient's health and is therefore relevant to the anesthetist. So let's a word about the classification of the drugs. As an anesthetist, what you need to know is what drug was given and what the side effects were. So I will just tell you what are the drug: alkylating agents, antimetabolites, topoisomerase interactive agents, antimicrobial agents, monoclonal antibodies, natural products, hormones, immune checkpoint inhibitors. So we don't need to know the classification, but we need to know what chemotherapy was given and what are the side effects of those particular chemotherapeutic drugs. So what does chemotherapy does on our organ systems? So normally it is for the cardiac toxicity and pulmonary toxicity that we need to do special investigations, because rest of the investigations, whether for kidney or liver or electrolytes, all are done during our routine investigations. So if you see the effect of chemotherapy on organ systems, first being the immune response, the immune system might be affected through myelosuppression, leading to chemotherapy-induced neutropenia. So this chemotherapy-induced neutropenia may require multiple transfusions, myeloid growth factors, or antibiotics may be necessary. And it can cause a reduction in number of erythrocytes, leukocytes, and platelets, causing pancytopenia, which can just decrease our oxygen carrying capacity. The risk of hemorrhage and opportunistic infections may much more increase. So what we need to do pre-op is you should have hemoglobin concentration, thrombocyte counts, and peripheral blood differentiation should be performed to exclude pancytopenia. And remember that in patients with severe pancytopenia, postponement of surgery should be considered until blood values have been recovered sufficiently. Another thing what the immune system may do is an inflammatory and procoagulant, antifibrinolytic, and pro-aggregative response may occur, which can lead to venous thrombosis. And the increased risk of thrombosis is sustained for up to 6 months. So here how our anesthesia gets affected, that anticoagulation may interfere, our careful timing with our neuroaxial techniques. Now coming to the most important toxicity, which is the cardiac toxicity. It occurs frequently and may evolve over a number of years. So these chemotherapic agents damage the myocytes in the heart, and as the heart has limited capacity to repair damage, these effects are prolonged, often presenting as left ventricular dysfunction, arrhythmias, and heart failure. So these are some drugs which cause cardiovascular side effects. The most common being what we see is doxorubicin and idarubicin. The other mean being cyclophosphamide and 5-fluorouracil, which are commonly given to the patients. So remember that not only echo, ECG changes, supraventricular arrhythmias, torsidopoints, then chronic dilated cardiomyopathy, everything can occur in patients, but not all in one patient, in different forms. Like in some patients may develop cardiomyopathy, some could have ECG changes. So we need to have what we need to say. This is one patient like who came to us, and if you see the patient, you can't even make out that there is something with the patient. But when we did an echo, it was left ventricular global hypokinesia. And the thing is that when we see the investigations, we see the echo. We say, echo is normal, but that echo was before chemotherapy. It's not taken after chemotherapy. So that is very important that your echo is done after the chemotherapy so that you can find out whether the, any effect has occurred of chemotherapy or not. So what investigations you need to do is a focused history and examination, a preoperative ECG, 2D echo, and lab tests which are not normally done, troponin and NTP, natriuretic and peptide should be obtained. But if cardiotoxicity is suspected, patients should be seen by a cardiologist for further evaluation and optimization. Another major toxicity what we see is respiratory toxicity. So what happens is, all of us know that bleomycin, It is the most commonly known drug which causes, in a concentration more than 400 international units, it can cause life-threatening interstitial pulmonary fibrosis. The lung injury develops within 6 months after the start of bleomycin, especially when high inspired oxygen concentrations are used. And in patients who are hypoxic, inspired oxygen should be titrated to achieve an SpO2 between 88 and 92%. So what happens is that this toxicity occurs within weeks to months after the start of chemotherapy. Patient may present with cough, dyspnea, hypoxemia, or low-grade fever. Physical examination may reveal basal crackles. And if you see the investigations in the X-ray, you can see it as a bilateral reticular markings. You can see ground glass opacity, consolidation. High resolution CT is sensitive but not specific. But very important test is the decreasing diffusion capacity of carbon monoxide. So if you see DLCO, if it is decreased more than 30%, it is very significant. So when these patients come to you for anesthesia, remember most of them are germ cell tumors which are in young males and females, mostly for testicular tumors or ovarian tumors. So whatever procedures they come for, most of the time we can, sail through by regional techniques. But if you have to give GA, you need to make sure that you give oxygen, try to give it at the, room air is 21%, say you give 30% FiO2 and you can FiO2 and keep the saturation above 90. Like if it's still 90, it's more than good enough. Plus at the same time, remember, try to extubate them on the table so that you don't require post-op oxygen. And what problems as an anesthetist we don't see on table as such. This toxicity will develop gradually post-op. But in my career of 27 years, I have seen one bleomycin toxicity on table. That was an 8-year-old boy. For them, the moment we didn't have air that time, this is some years ago, we were just oxygenating the child with 100% oxygen. A clear chest turned into a chest full of rales, rhonchi, and it was such a surprise for us that we called a pediatric oncologist. They said it happens because of release of oxygen radicals. Steroids were given. Patient was brought out on the table, extubated, and surgery was deferred that time. So I have not seen, except that child, I have not seen on table. But yes, if we follow up these patients, we may get to see that how many of develop oxygen toxicity if we don't take care of these patients. So these are some drugs which cause a pulmonary toxicity. It's not even bleomycin. There are so many other drugs which cause, it's only the intensity differs. So we should take diagnosis of exclusion and if required treat with systemic glucocorticoids, stop the causative agents and give supportive measures. Another organ which gets affected is the kidney. Now, most of the drugs are often eliminated by kidney and can lead to chemotherapy-induced acute injury. An acute kidney injury can present with proximal tubular injury and present with proteinuria, phosphate wasting, Fanconi syndrome, or magnesium wasting. So what you have to remember, a very important drug which is really causes kidney injury is cisplatin. It is one of the most widely known chemotherapeutic agent, and this is the drug which is being used for HIPEC surgeries, and where we give directly intraperitoneal this chemotherapy drug. So it causes a decrease in GFR, increased creatinine, decreased serum magnesium concentration, which are mostly dose related and reversible. But when you are doing HIPEC and cisplatin is given, you need to really take care of. So for these kidney patients, preoperative management and evaluation of GFR and electrolytes are essential who are exposed to nephrotoxic agents. Patients with severe kidney dysfunction should be treated postoperatively with adjusted doses of drugs excreted by the kidney, for example, some opioids, and a balanced approach to fluid management. So these are the drugs which can cause kidney damage, which can cause alloguria, acute kidney injury. Coming to liver, chemotherapeutic agents are mostly metabolized by the liver, and this is affected in patients with pre-existing liver disease. So hepatotoxicity is mostly asymptomatic and is limited to increase in liver enzyme, but in severe cases it can cause inflammatory hepatitis, cholecystitis, steatosis, and end-stage liver disease may occur. So basically what we need to do, if we are expecting liver toxicity, we should just get pre-op enzymes done. These are the drugs which can cause toxicity to the liver. Then another organ which can be affected is the brain. The effect of CT on organ, neurological effects or neurotoxicity. it is an important limiting factor for chemotherapy regimens. And the development of neurotoxicity depends on the cumulative dose and dose intensity. But it is also more frequently seen in patients with diabetes, increased age, hereditary neuropathies, and earlier treatment with neurotoxic chemotherapy. It can be peripheral neurotoxicity where you need to take care of autonomic dysfunction. It can be a central neurotoxicity. So you need to be careful to find out whatever the neurotoxicity is, to do a comprehensive neurological examination before taking up these patients. Remember, for autonomic dysregulation and the use of regional anesthesia is not contraindicated, but pre-existing neurological abnormalities should be documented, because I think all the pain specialists, when they are giving Vinca, alkaloids, or these drugs are given and patient has a neuropathy, it is very, very essential to document it, because later it may happen that you have given a block or you have given, even spinal epidural, and it can be attributed to that rather than the, so documentation for medical legal purposes and for yourself is very, very important. Some other effects of CT can be patients can have alopecia, all of us know, cystitis, infections, GI effects, nausea, vomiting, and other innumerable side general reactions can occur. This is just to say that what are the common cancer drugs used for each, surgery. So, as an anesthetist, just we need to know, as we keep on, like, I will know in a 27 years if a breast case is there, what chemotherapy was given. So I would be knowing what side effects I should be. But if you're going as a new anesthetist and you are in a private practice, you should ask what the drug is and what the side effects are. Coming to a major thing is radiotherapy. Now, it is very essential that we should... This is okay? That is better. So radiotherapy, just remember that we have to find out which part of the body radiotherapy was given. One, radiotherapy, remember, if it is given in any part of the body and if there's a gland there, it starts hypofunctioning. So it can be pituitary or hypothyroid or hypoadrenalism depending upon that. Then another very important thing is whichever part, if it is given in the chest, if it is given the mediastinum, so your lung and heart, so many times patient you will induce a cancer patient and you'll see arrhythmias. You will all attribute it to the cardiac issues because of his cardiac. But it may happen that because of radiotherapy, the SA node has got fibrosed or the coronary artery fibrosis has occurred. So you need to know where the chemotherapy was given and radiotherapy was given. So depending upon the area, and the biggest area which we are bothered is the head and neck area. In the following slide, I will tell you in detail. So the generalized reactions can occur. All other systems can be involved in radiotherapy. So basically, immune system, cardiovascular system, pulmonary and head and neck. It is also like chemotherapy that wherever radiotherapy is given, not only that area, but the surrounding area also gets affected. Though we have now targeted therapies where they want to give that particular organ radiotherapy, the radiotherapy acts there only. But those machines are not available everywhere as such, still. So we need to find out where it is given and what are the side effects associated with the radiotherapy. So one can be thrombosis. One, as I said, for the cardiac, pericarditis, arrhythmias, pericardial effusion, QT interval prolongation and coronary artery disease. If it is given in mediastinum, pulmonary edema, pneumonitis, fibrosis can occur. Now comes this effect of radiotherapy and head and neck. So what actually happens is there is mucositis, dryness, so whatever you are putting a nasal tube and all, your bleeding will be more. Second thing is that whenever radiotherapy is given in head and neck area, first their swelling occurs. So after the swelling occurs, then it gets fibrosed. So even if the mouth opening is good enough, when you try to do a scopy, you may not be able to lift the epiglottis. So depending on that, osteonecrosis, trismus, dysphagia, change in airway, hypothyroidism can occur if the radiotherapy is given in head and neck area. So you should be aware of difficulty in airway management, because you may just go to start a case, you won't know patient is post radiotherapy, mouth opening may be adequate, but that will not help you to, you may have a difficulty in airway. So it can be mask holding and ventilation because of osteonecrosis, mucositis, lack of dentition, decreased mobility of neck, and edema from radiation. So if you see this patient, if this patient I was continuously asking to take out his tongue, but he is not able to take out his tongue, that is, that itself protrusion of tongue is not there, gives you a sign that it may be a difficult intubation. This we just did day before yesterday, that's when I took it, that because of fibrosis, trismus and restriction in mouth opening, decreased mobility of tongue and neck, glottic and epiglottic edema may impede visualization of normal anatomy. So careful preoperative airway assessment and planning can occur. You can see the thickness of the epiglottis here. This is post-radiotherapy induced. So when you are managing such cases, remember that you have to assess these cases, you have to know the timing of surgery, you have to prehabilitate them. So whenever this patient comes, note the patient's neoadjuvant therapy and possible toxic effects reported. Do the physical examination. Remember that there should be several weeks to allow a reasonable recovery from cytotoxic adverse effects and a reduction in disease volume, thereby optimizing condition for surgical resection. A time to surgery of 4 to 6 weeks is often considered the optimal interval to achieve these goals. You have to prehabilitate them with, to improve their functional status, to enhance post-op recovery and improve their physical performance. Nutrition-wise, you need to improve them. You need to give them a psychological support because before surgeries, these patients may suffer from anxiety, depression, and low self-efficacy, which is associated with worse physiological, surgical outcomes and post-operative quality of life. You need to, for that psychological support, you have educational programs, procedural and sensory information to patient, and cessation of smoking and alcohol consumption to be addressed. A good thing you need to do is to get them exercise trained because they would have lost muscle mass. They need inspiratory muscle training, aerobic or CPT training to increase the strength and endurance of inspiratory muscles. So remember that integrate a multimodal prehab program into the interval between neoadjuvant therapy and surgery. So this is just a table to show what pre-op considerations we need to take and how we have to manage, which I have already highlighted to you. And remember that preference of general or regional anesthesia and management of patients with toxicity from therapy because neuroaxial techniques can provide optimal post-op pain relief, especially in patients with long-term opioid consumption and might also decrease cardiopulmonary risk in patients with neoadjuvant therapy toxicity. I think by this slide, I am fit enough to be in this session. Am I right? So another thing which is that the interactions with anesthetic agents may be there and they're poorly studied and published, but yes, they have given some drugs which can, interact with the chemotherapy drugs. So to conclude, I'll say neoadjuvant therapy consists of either chemotherapy, radiotherapy or immunotherapy. It is associated with toxic effects on different organ systems. These toxic effects may interfere with the perioperative care but may also cause a deterioration in patient's general condition to such an extent that the risk of perioperative complications increases. Thirdly, during preoperative assessment, a structured history, physical examination and additional examination should be performed to detect toxic adverse effects from neoadjuvant therapy, and optimization before surgery is essential, and multimodal prehabilitation before surgery to lower these risks. Thank you for the patient listening.